Good morning to everyone. My name is Jason Bliss, and I am the Executive Director for the Washington Alliance of Quality Recovery Residences. I will be your moderator for today's webinar on trauma-informed care in recovery residences. Today, we have the privilege to be joined by two wonderful professionals. Milena Stott is a licensed clinical social worker and a substance use disorder professional. She started her social work career working with children and families. As a clinician, she gained experience in various settings across the continuum of care for both children and adults. No matter the setting, trauma and adverse childhood experiences were a common theme in the lives of people. As a clinician, she helped her clients find the support and interventions to heal. As a supervisor, she helped others understand how to work with persons who experience trauma. Today, Milena provides training and technical assistance, and also does outreach and engagement with the Fletcher Group to promote quality and capacity for recovery, housing, and recovery support. Today, we are also joined by Garrett Kostin. Garrett has his master's in social work. He started his social work career with immigrant and refugee communities in the Thailand-Myanmar border in 2009. Since returning to the US in 2014, he has gained valuable experience in working both with inpatient and outpatient professional health and medical settings. He currently serves as a behavioral health consultant, facilitating workshops and trainings on person-centered and trauma-informed care, motivational interviewing skills, medications for opioid use disorder, and other topics. He is energized by innovative person-centered initiatives that aim to reduce disparities and inequities in healthcare and society. Just for a brief bit of housekeeping, I'm sure that you all will have questions and such that will come up as our presenters present here today. As you have questions, feel free to either drop them in the question and answer or in the chat box. And as we go along, they will be answered. If we don't get to them at that time, we will definitely do our very best to get all of the questions answered at the end of this presentation. And with that being said, I'm going to go ahead and turn it over to Garrett and Milena.
All right, good morning, everyone. Thank you, Jason, for the kind introduction, and thank you, everybody, for being here today. Garrett's going to do most of the presenting today. I am here for backup support and conversation support. So I'm going to kick it off to Garrett in just a second. One thing that I would like to say is that the Fletcher Group provides technical assistance and training to rural communities across the nation, with the goal of increasing the quality and capacity of recovery housing. So we're very happy to work here with the Washington Alliance for Quality Recovery Residences and their leadership in that space. So happy to be here delivering this topic to you all today, and I'll turn it over to Garrett. Thank you.
Thank you, and good morning, everyone. I'm Garrett Kostin. I'm very honored to be with you all this morning, and also with those of you in the future who I hope will be watching this archived video. We're here this morning to discuss the intersection of two topics that are really very important to me and have been for several years. The first one is understanding more about the effects of trauma and different approaches to reducing their severity. And the second topic is supporting those struggling with and in recovery from substance use disorders with some of the most individualized and compassionate evidence-based approaches that are available to us today, including trauma-informed care. So to give you a little bit of background or insight about how my interest in these topics began, I'd like to share that back when I was a social work student at the University of Washington, I had the opportunity to do an internship with Lifelong AIDS Alliance in Seattle. It was my first exposure to social work in the US. And I mostly conducted intakes with new clients coming into the organization for services. As I imagine you can understand, it didn't take long for me to see the commonly interrelated nature of traumatic experience, substance use, and adverse health effects. And the insight that I gained, the eye-opening experience that I had back then during that internship has strongly influenced my professional interests and my career experiences in the years since. So I feel really privileged to be working today with you all and to be hosted by WAQRR to share some of what I've learned with you all today and to have some fruitful discussions. If you haven't already, I invite you all to briefly share your names, the role that you serve in your organization and your city in the chat box, so we have a better sense of who our participants are this morning. And with that, I'll move on to our objectives. Today, before 11:30, in the next hour and a half, this is what we hope to accomplish. We will be defining and developing our understanding of trauma, traumatic stress, toxic stress, and adverse childhood experiences, also known as ACEs, along with their correlation with substance use. We'll also define and explore principles of trauma-informed care, learn about trauma-informed frameworks, therapies, and approaches that can be utilized very effectively in recovery environments and residences, and also describe the importance and value of applying those trauma-informed care approaches. So before we get into those topics, I was hoping to ground us with some foundational or principle guiding principles that Milena and I bring to this presentation today. The first one is that we hold that each and every one of us is dedicated to improving our collective capacity to support the holistic wellness and recovery of all individuals with SUDs. We also understand that trauma and substance use go hand in hand. And some quick statistics to support this assertion are that folks with diagnoses of PTSD are found to enter SUD treatment at 5 times the rates of the general population. And also, an estimated 90% of folks with SUD diagnoses are estimated to have a trauma background. So these are highly correlated conditions, trauma history and substance use disorder. Also, substances, we understand that substances are initially, at least, an effective way of relieving, soothing, or distracting from painful and debilitating symptoms of trauma. This principle can help us develop our empathy and compassion for those struggling with these issues. And the final principle is that for one to successfully change their problematic relationship with substances, it will very likely be necessary for that individual to be well supported in developing healthier ways of coping with stress and trauma symptoms, which is where I believe you all come in and have a role to play here. So let's make sure that we understand what we're talking about, that we're all talking about the same thing when we talk about trauma. This first definition here is from SAMHSA. Individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. It's perhaps an appropriate time to note that an estimated 50 to 60% of folks in the US are expected to experience at least one traumatic event during their lifetime. And we know from research that trauma exposure at younger ages and traumas of more personal and life-threatening natures are more highly associated with the development of post-traumatic stress. And this is another useful definition that I came across recently in a book on harm reduction. And that definition is that trauma refers to any experience that, one, is beyond the realm of normal and expected human experience, involves actual or threatened death or injury, either to oneself or others, causes fear or horror and intense physical or emotional distress, and finally, overwhelms one's ability to cope, even for a short time. My takeaway from this definition is that folks struggling with long-term effects of their exposure to trauma, those, for example, who may meet the criteria for a diagnosis of PTSD, commonly have extreme difficulty in calming their body and their mind's stress response system, their survival instincts, their fight, flight, or flee instincts. And think about people, or it could be even within your own experience, of folks who are seem to be constantly on guard, monitoring their surroundings for any dangers or threats, unable to relax, unable to manage difficult emotions or to shut off distressing thoughts. And when someone lacks sufficient skills or resources to manage symptoms like that, as I mentioned earlier, substances can seem very appealing and useful in their ability to numb, distract from, or temporarily relieve those intolerable feelings. So let's get into, I'd like to, one thing I forgot to mention, I don't believe Jason mentioned it, is that if there are any, he did mention it, but I'll just reiterate it. If there are any questions, or if anybody isn't on board with anything that is shared in this presentation, please feel free and encouraged to share your perspective or your question in the chat box, and we will seek to save some time at the end to read those out and respond to them. So next are some examples of traumatic experiences, and these are in the categories, as you can see, of natural disasters. These are furthest away from an individual, and then community or national events and circumstances, traumatic experiences and events that happen within the family, and then personal experiences that happen to an individual. And I'm not going to read through the table, but you're encouraged to look over that. But one thing that I'd like to point out is that some of these examples we have much less ability to control or prevent, while others do have the possibility of being mitigated or prevented with sufficient family or community support. And two concepts that are useful when we talk about different traumatic experience are those of proximity and duration. Proximity in this case in this context is about how close the traumatic event comes to impacting or touching an individual. And duration is not only about how long the traumatic event persists, but also about the number or occurrences over time. And in general, the more intimately or closer and longer term the experience affects an individual personally on an individual level, the more traumatic that event will be experienced for that person. And it's also important to remember that trauma can include threats to the lives of even strangers that we witness. But in general, those types of trauma don't impact us as severely as threats to our own lives or the lives of those we know and love. So some more terms to define here: traumatic stress, toxic stress, and adverse childhood experiences. So let's talk about how some of the effects of trauma and how the exposure to traumatic experiences can affect our physical and mental health, and our likelihood to engage in risky behaviors, and our overall ability to fulfill our individual potential. So when we talk about traumatic stress, we're referring to the body and mind's response to exposure to an adverse event. We have a short video coming up that's going to illustrate this, the body's response to trauma exposure. It's typically initially fear, shock, or numbness. And when it persists longer term, it can look like unpredictable and difficult, challenging emotions, intrusive memories and flashbacks, physical and mental health symptoms, and more. The toxic stress is differentiated from traumatic stress in that it's the stress response that occurs when a person experiences multiple, frequent, and/or prolonged adversity without adequate support. And toxic stress is the type of stress that can cause lasting impairments with mental and emotional functioning. And I want to just point out that both of these, traumatic and toxic stress, not only deplete our mental and physical energy, but also have very real corrosive effects on our immune system, in addition to our mental and physical health. Next, adverse childhood experiences, or ACEs. These are stressful or traumatic events, including abuse, neglect, and household dysfunction, that occur during childhood and can have enduring negative developmental and behavioral effects. The theoretical concept of ACEs, or adverse childhood experiences, is really a very useful model to help us understand how the stress resulting from traumatic childhood experiences leads to impairment in social and emotional functioning, including development of substance use disorders and eventually negative health outcomes. So at this point, let's watch a brief animated video that lays out some of these concepts, especially how ACEs can negatively affect the developing brains of children and how they can impact lifelong development and functioning. I'm gonna get the video queued up and mention that just to give credit where credit is due, this video was put together by Dr. Andrea Gonzalez at McMaster University in Ontario and the Canadian Institutes of Health Research in 2018. And we're going to be watching approximately just the first 4 minutes of this video. And I apologize in advance if we have to suffer through any advertisements. If we do, it should only be for about 5 seconds. There it is.
Grammarly can help. This sentence is grammatically correct. Child's experiences early are important building blocks for the developing brain. Genes, nature, are like the blueprint. They provide the basic framework for brain development. However, genes do not design the brain completely. Environmental influences, nurture, fine-tune how the brain works by shaping which brain connections get used. Connections that are used more.
Garrett, are you able to turn the sound up at all on your end? It's just not coming through very loudly.
Right, I think I know what I forgot to do. So let me restart it. I'm gonna have to start the sharing. Thank you, Pamela, for letting us know so everyone wasn't sitting there for the entire video. Give me a second. Okay, make sure share sound is selected, and here we go again.
A child's experiences early in life are important building blocks for the developing brain. Genes, nature, are like the blueprint. They provide the basic framework for brain development. However, genes do not design the brain completely. Environmental influences, nurture, fine-tune how the brain works by shaping which brain connections get used. Connections that are used more grow stronger and more permanent, whereas ones that do not get much use fade away. Together, genes and the environment build the foundation for all future development. Safe, stable, and nurturing relationships early in life lead to healthy development. But children's brains capture other experiences as well. Stressful events. However, not all stress is bad. Positive stress involves normal childhood experiences, like starting daycare or meeting a new person for the first time. This stress is essential for healthy development because it helps children develop coping skills and confidence. But when stress is frequent, chronic, and uncontrolled, it is toxic to children, especially when they do not have a caregiver to provide support or buffer the stress. Adverse childhood experiences, ACEs, such as abuse, neglect, exposure to intimate partner violence, parental depression or addiction, and poverty, are toxic stressors which could lead to lifelong changes in learning and behavior. ACEs early in development can impact social, emotional, and cognitive functioning, increased risk-taking behavior such as drinking and substance use, and increased risk of disease, disability, and social problems later in life. The question is, how do adverse childhood experiences impact a lifelong development? One of the most important systems in our body is our stress system. It's activated when we experience stress. We become alert, our heart rate increases, and so do our stress hormone levels, cortisol and adrenaline. Our body is ready to react, what is known as fight or flight. A short period of time after the stress is over, or if a child receives support from a caregiver, the stress response turns off and the body returns to a normal state. Adverse childhood experiences create stress responses that stay active, and without the support of a caregiver, the system has difficulty shutting off completely. This constant and prolonged activation can affect immune system functioning and increase the chances of sickness, infection, and disease. Prolonged activation of stress hormones is also toxic to the brain. Certain areas of the brain are more vulnerable to toxic stress, including the executive center or the brain's control center, an area important for solving complex problems, attention, reasoning, impulsivity, inhibition, and learning. A second area is the emotional center, the brain's alarm system, which is involved in processing and interpreting emotions and the ability to control impulses. The third area is the memory and learning center, the brain's filing cabinet, which plays a major role in learning and the formation and retrieval of memories. Science shows that adverse childhood experiences impact all of these brain centers. Behaviorally, what we begin to see is emotional distress, poor emotion regulation, greater impulsivity, learning difficulties, and physical and mental health problems.
Okay, we're going to stop it there. And that last part on the, let me share the presentation again. All right, so that last part that we saw in the video where the presenter covered some of the effect of ACEs on the brain and how those effects can play out behaviorally is really the core of the connection between ACEs and problematic substance use. To review, the behavioral manifestations resulting from ACEs that were mentioned at the end of that video were increased emotional distress, difficulty with regulating emotions, an increase in impulsivity and impulsive risk-taking, and as well as learning difficulties and then mental and physical health conditions. As we all know, as those working with folks in recovery from substance use disorders, those are also all the common driving factors for the development of those SUDs. So my takeaway from understanding and learning about the concept of ACEs and the long-term effect on a child who's exposed to them is that if we really want to try to reduce substance use in the future, prevent people from developing SUDs in the first place, we need to be focusing much more intensely on protecting children from exposure to trauma, and also making sure that children have the sufficient support and skills to reduce the impact of adverse experiences that some of them will inevitably encounter. And this is really the core of primary prevention of substance use disorders, in my opinion. So to give you a little more background about where this knowledge comes from, where our understandings about ACEs and the effects and the correlations with substance use comes up, I'll just give you a brief background about the initial ACEs study, which was a very large study carried out in the late 1990s and initially published in 1998. It was a collaboration between the Centers for Disease Control and Kaiser Permanente, with a total of 17,000 adults who completed surveys and interviews about their childhood experiences, along with their current health status and behaviors. So it was a very large sample from across the country, 17,000 individuals. And here on this slide, you can see some of the specific childhood experiences that were screened for, including substance abuse in the household, physical, sexual, and emotional or psychological abuse, domestic violence in the household, neglect, and further research on the prevalence and effects of ACEs continues today. And I think a positive development is that the research findings about ACEs and the effect that they have on individuals throughout their lifespan is beginning to play an increasingly large role in program treatment and policy planning. It's important to note that many other potential sources of childhood trauma are actually not reflected in the initial ACEs survey. For example, things that we know that can cause trauma, such as housing and food insecurity, homelessness, pervasive racism and other forms of discrimination, and exposure to community violence were not included in the initial survey. So some of the findings of the original and subsequent ACEs study are here on this slide. It's really without dispute that there is a very strong correlation between ACEs and a number of high-risk behaviors, including SUDs and negative health outcomes across the lifespan. Trauma is in general not something that happens to someone without having a lasting effect and change on their development. Of the most common illnesses in the US, addiction was found to have the second highest correlation with adverse childhood experiences, with COPD being the only one that ranked higher than addiction. And for folks with exposure to 4 or more adverse childhood experiences compared to folks with no ACEs, they were found to have increased risks for COPD, sexually transmitted infections, and suicide attempts at the rates you can see on this slide. And those who revealed that they had experienced 6 or more adverse childhood experiences were found to have a 250% greater rate of smoking compared to those with no ACEs, a 500% greater rate of alcoholism than those with no ACEs, and very startlingly, a 4,600% greater rate of use of street drugs, injecting street drugs, than those who with no exposure to adverse childhood experiences. So it's useful to understand a bit how similar traumatic experiences can lead to different responses and different outcomes for different individuals. Milena and I were talking about this yesterday. We anticipate that some of you might have questions about, well, how come, I had some adverse childhood experiences, but I don't feel like I'm struggling with trauma or that it had a lasting negative impact on my development. It's an important point to make that all trauma is inherently subjective. It's about how an individual experiences that event. What one person may experience as traumatic isn't not traumatic simply because another person doesn't experience it or struggle with the effects of it in the same way. And on these next 2 slides, we lay out some of the factors that either reduce someone's resiliency in the face of adversity and exposure to traumatic experiences, and factors such as these ones here, risk factors that increase one's vulnerability to developing traumatic or toxic stress following exposure to ACEs. They're in the categories of biophysical, psychological, social, and spiritual. And they include we can conceptualize them as deficits that someone brings to their experience of trauma. If somebody has a history of trauma in the family, or a chronic medical condition, or poor nutrition, just a stressful life such as housing or food insecurity, poor academic achievement, if they've been exposed to discrimination or if they've witnessed domestic violence, also if they have low self-esteem or low concepts of low self-worth for themselves, all of these things can increase one's vulnerability to stress, and also increase their vulnerability to developing substance use disorders, for example. And on the flip side are some protective factors. These factors explain why some are able to adequately cope and recover from adverse experiences, even in childhood, without lasting effects or severe negative outcomes. These are the strengths that someone might help them buffer them from the impact of trauma. So this would be secure housing and having all of their essential needs met. Strong physical health with including nutrition and exercise and development. Strong supportive relationships with those in their family and their community, as well as access to additional support when necessary. Some of the psychological and spiritual strengths that can help protect someone from traumatic stress include strong positive self-regard, future orientation, motivation for achievement in the future, and having had the opportunity to learn and develop some effective coping skills, such as problem-solving skills and emotional regulation skills. So all of these protective factors offset the risk factors and sort of build recovery capital. All right, at this point, we welcome you all. I don't think it's going to be possible because we're in a webinar setting to have you all speak out, but we'd like to invite you to participate in the chat box by letting us know some of your initial reactions to this information thus far. What is all of this about trauma and adverse childhood experiences mean for our work? And what are some of your initial thoughts about what we can do about it, how we can respond? We'll give everyone a couple minutes to share their thoughts in the chat box, and then I think Milena is going to read some out.
Thank you, Garrett.
Mm-hmm.
I see that we have folks here from crisis systems, and we have somebody here from Life Resources, Hope Street, maybe that's a housing setting. How is this manifesting in your work?
Mm-hmm.
So it looks like, Karen, thank you for the response. So Karen says that we need to be responsive to clients' needs and trauma, meeting them where they are. Yes, thank you, Karen. And we will talk a little bit about interventions in the next half. So that's a great comment. You know, I often think about, you know, when Garrett, you were sharing those protective factors in housing, you know, since we are talking about recovery housing here,
Mm-hmm.
you know, I'm just curious to know, what are folks finding in recovery housing settings or in other housing settings around trauma or even access to housing as a protective factor, and how that's maybe changed somebody's life. The role of social support in recovery settings, in addressing trauma. Those are all, you know, thoughts that are kind of running through my mind. Does anyone other than Karen have anything else they'd like to share or add? We'd love to hear from you. All right, thank you. It looks like Kristen, PTSD from trauma can make communal living challenging. That is correct. And that's actually a really good thing to think about, right? As WAQRR does a lot of trainings around supporting topics of interest. And so we are definitely noting the challenges of that related to this. Karen, they are not all really recovery housing, and some, even though they have some rules around recovery, they don't actively enforce those rules. Yeah, thank you for that comment, Karen. And that's actually pretty consistent nationally. There's a lot of, I guess, definitions of what people consider different housing types, but yeah, recovery housing has a very specific definition.
Yeah, and Karen, if I could interject a little bit, your your points and your observation about the recovery housing, there are, unfortunately, it's just a fact that here in Washington State, we have some operators that are out there operating under the guise of actually having businesses that provide recovery housing, when in fact it's not so much the case, unfortunately. But here now with WAQRR, one of our goals is to be able to reach out to those providers to offer some strength and support and some tools, so they're hopefully able to do a better job at actually providing the recovery housing that all of our clients so desperately need.
Yeah, I would add to that. I mean, Washington established WAQRR and the Recovery Residence Registry and related funding, to address some of this, right? Encourage people to create settings that are conducive to recovery. There's also discussions around operations funding, right? Because sometimes these aren't all medical services and they're not residential treatment facilities. Access to those is quite limited. And then stepping down into a different environment also requires some other support services. So I think that these are all really good points. And I know that we're having those conversations, and part of the goal of this training today, right, is to really invite participation in a lot of that process and reach communities to understand what they're experiencing and to make sure that we're all aligned in providing the right resources and trainings for folks out there. I see here that Shayna says, my team meets with people who are experiencing their worst day. And they work with them to soothe them and provide support. Karen adds that many clients have real concerns about sleeping space, and that is a concern for sure. And maybe Garrett can address some of that in the second half and interventions on how to support. I believe only these on the registry are considered recovery housing. Yeah, so that there are a lot of conversations around who gets on registries and what level of qualifications do those homes have to provide support. And the criteria also include sleeping space, right? Is to make sure that sleeping space and personal space is adequate and trauma-informed and meets the needs of folks. So. Thanks everybody so much. I wish we could engage in a dialogue about it, but I am taking note in all of this. All right, I'll turn it back to you.
Thank you, Milena and Jason, and thank you all who shared your comments. I actually haven't come across any specific suggestions for responding to folks' concerns or discomfort with sharing sleeping space. But definitely in the second half, we're going to be sharing lots of tips and suggestions for developing trauma-informed and supportive environments that might help mitigate some of those challenges for folks. So thank you for participating in the discussion.
Yeah, Garrett, just one more comment here. Karen shared the example that there's a house with 5 beds in one room. And I'd love for you to reach out to Jason or Alan and connect on that. There are supports that the system can offer in some cases.
Yes,
go ahead, Jason.
Most definitely, Karen. Karen, I'll put my direct email in the chat for you to reach out, and you and I can have a further conversation. There was recently some legislation passed that will take effect in January of 2023 that will greatly limit and reduce, we'll say, the unethical providers that are out there operating under the guise of being recovery residences. It's just it's a travesty, in my opinion, when individuals get out there and open houses and have 5, and I've even heard some horror stories of 5 sets of bunk beds in one room, and in reality, that's not what recovery is all about. That's not what recovery housing is all about. And in my opinion, they're doing our clients far more harm than good. The whole goal of WAQRR is to be able to find these individuals, to reach out to them and have some candid conversations about what recovery housing really looks like. So many more things are coming with legislation and stuff like that. But Karen, I do encourage you to reach out to me, and we can have more of a conversation concerning this.
Mhm. Yes, I am just getting memories of a specific individual I worked with who went straight into a recovery house following 28 days in inpatient treatment, and he was actually paying rent to sleep in the tool shed, disconnected from the house. And fortunately, the latest I know about that individual is that he's doing well, but his recovery has been very rocky, and it definitely wasn't surprising when he relapsed shortly after living in a recovery home where he believed he was going to be getting sufficient support and adequate housing, and he was actually living in a tool shed that did not have any plumbing, much less electricity. So hopefully, through the work of WAQRR and all of your dedication and compassion, we're going to be hearing less of these negative and really unfortunate stories in the future. All right, to move on in the presentation, we're ready to get into defining and understanding some of the details about trauma-informed care. So, you know, hopefully from the video, even if that was just your first opportunity to learn a little bit about the brain's response and the lasting effects that traumatic experiences can have on folks, that's one way to really help understand the correlation and why substances can feel so attractive and soothing to folks today. And also, fortunately, this knowledge about the correlation provides us with some useful pathways for understanding what types of support a traumatized individual may need in order to mitigate some of the harmful changes that the trauma brings on. And this is where the concept and practices of trauma-informed care come in. So here on this slide are some defining points and features of trauma-informed care. TIC is an approach in the human services and clinical fields that assumes that an individual is more likely than not to have a history of trauma. If someone doesn't have exposure to trauma, is not struggling with the effects of traumatic or toxic stress, they're also not going to be harmed by having any of these features of trauma-informed care in their environment. It's probably going to serve them well as well. But it's a pretty safe bet that someone who's receiving services has had a history of trauma. Next point is that trauma-informed care understands, considers, and actively seeks to address the pervasive and detrimental nature of trauma, including that among service staff. And the last point is that trauma-informed care promotes environments of healing and recovery rather than practices and services that may inadvertently re-traumatize. I'm going to talk about re-traumatization in a few more slides. This is another great definition that helps our understanding of what trauma-informed care is and is not. And it comes from the Butler Center for Research in a publication from the Hazelden Betty Ford Foundation. Trauma-informed care is a collection of approaches that translate the science of the neurological and cognitive understanding of how trauma is processed in the brain into informed recovery-oriented practice for providing services that address the symptoms of trauma. These approaches are not designed for the treatment of the trauma experience per se, such as with trauma counseling or processing of the trauma narrative, but rather for assistance in managing symptoms and reducing the likelihood of re-traumatization of the individual during the care experience. We understand that most operators and staff peers in recovery residences are not trained clinical professionals in the treatment of trauma, and nor do we encourage them to attempt to provide those interventions. However, there's definitely a role to play, as we're going to explain in the coming slides. All right, so with these are some prerequisites for trauma-informed care, some of the basics that need to be in place before trauma-informed care approaches can be implemented and be successful. Without these pieces that are outlined here on this slide, without these pieces in place strongly and consistently, there is a very real danger of treatment trauma occurring. And the definition of treatment trauma is that it refers to experiences in SUD treatment and recovery homes that can cause psychological or emotional harm. And these include shaming, aggressive confrontation, verbal abuse, discriminatory treatment based on individual characteristics, not talking about someone facing the consequences of breaking some policies of the house, but simply because of individual characteristics that they bring. Also demeaning language and isolation or exclusion from group activities in the treatment setting or in the recovery home. As you can understand, all of those practices that I mentioned can serve to reduce someone's already low self-esteem, self-confidence, self-worth, and certainly their feelings of safety. In addition, treatment trauma can easily trigger trauma symptoms that led initially to one's problematic use of substances in the first place. So we really need to be careful about avoiding incidents of treatment trauma, because it can really perpetuate the tragic cycle of a traumatic experience, stress resulting from that, soothing with substances, attempting sobriety and recovery, being re-traumatized or having our traumatic stress triggered, and then again relapsing with substances. So some of the factors that all trauma-informed care principles and approaches assume and depend upon are these, including language sensitivity, being aware of the power of our language and how it can affect someone. Attempting to always use non-stigmatizing language that is neutral rather than penalizing or shaming. Cultural sensitivity and humility, understanding that we can't understand every culture that's out there and the way that it affects different people in society, but we can be open and curious and have some humility about it. Also, inclusionary and non-discriminatory practices based across all different demographics, using strength-based rather than deficit-based focus, and attempting to always foster the self-empowerment and self-worth, self-esteem, self-efficacy of those in recovery. So once we've ensured that the culture and practices of our recovery environment, the recovery house, contain all of the basic components of trauma-informed care, and we've done our best to lower the risk of treatment trauma or re-traumatization occurring, our next task is then to consider how we can start implementing some of the core components of trauma-informed care, if they're not already present and prominent in our recovery residents. And those principles include safety, paying attention to every individual's perception of their safety in the recovery environment, physically, emotionally, intellectually, or ideologically, their opinions and their ways of interpreting the world, and also spiritually. This is, I believe, where sharing sleeping space would come in. And that is, I'm happy that that's the first bullet point, because that is something that definitely needs to be considered and addressed. Also, trustworthiness and transparency as part of the culture of the home. Respecting voice and choice, eliciting the opinions of every individual in the home, and making sure that they have some choice as to what occurs on a day-to-day basis, even some input with policies of the house, perhaps. And that's achieved really successfully when there's collaboration and mutuality, sort of shared decision-making ability, sharing some of the power. Also, peer support and mutual self-support is very important, very fundamental in developing self-empowerment and self-confidence. Learning from each other, learning from peers, maybe just as much or even more than learning from the so-called experts, professionals, or those in charge of the home. Also, making sure that there's opportunities to foster empowerment and to increase resiliency in the face of challenges. Inclusiveness and shared purpose. Again, opportunities for engagement in purposeful activities. I know that it varies across different recovery residences and different folks' circumstances, but whether or not employment is a requirement of residency in a recovery home, there should be opportunities for purposeful activities. and this can even be participation in chores of the household, meals, gardening, things like that. Things that foster a sense of purpose and give an opportunity for folks to feel that they have something to offer, something to contribute, and that they are competent in some areas. And finally, and this can often be the most challenging, this is sort of a more advanced principle of trauma-informed care, but opportunities and initiatives that seek to address or redress cultural, historical, and gender issues and dynamics, sort of the components of that might feed historical trauma or discrimination, and that we can work to decolonize, at least in our recovery environment. All right, so this here is a great graphic I came across that lays out how agencies and care settings, including recovery residencies, can demonstrate their commitment to trauma-informed care and begin implementing some of the key practices. This comes from an organization called Trauma-Informed Oregon. And we see here that at the top, we have the foundations, the pillars of trauma-informed care, and that filters down to on the agency or the recovery residence level to a commitment to trauma awareness, understanding the effects of trauma, the prevalency, and the effects that it can have on folks down the road, including the second part here, understanding the impact of historical trauma and oppression. And the ways that agencies can demonstrate trauma-informed care is through policies, procedures, and practices that, along the bottom level, create safe context with some of the points you can see, restore power and agency for individuals in recovery, and also build self-worth and increase senses of competency and self-worth among individuals, including respect, compassion, acceptance, and non-judgment, and collaboration and shared decision-making. Okay. So, what is your role in trauma-informed care? As I mentioned, we don't assume that many, or if any of you, are actually trained therapists with experience and certification in the clinical treatment of trauma. So as recovery residents, operators, peers, or support staff, what might your role be in ensuring and providing trauma-informed care for the individuals you serve? These are some guide points. First of all, providing compassion and empathy with a trauma-informed lens. There was one of the comments from the chat box session. Somebody mentioned that her staff gets to work with folks on their worst day, and she encourages them to sort of bring some life, bring some hope to them. And that's what's captured by this first point. The next one is to make sure that you're able to offer information on programs and services that address trauma and provide support for developing coping skills in the face of trauma, including trauma counseling or therapy. Understanding the individual's viewpoint regarding their own situation. What is their understanding of how they came to be in recovery at this point in time, and sort of how did they explain maybe their involvement or problematic use with substances. As operators and staff in recovery residences, you can explore, model, and practice with individuals new coping skills. That's really a key component. It's outside of the scope of our time today to be able to go into some coping skills. But if you don't have sort of a robust toolbox of coping skills that you found that work for you and that you can share with others in your recovery residencies, I really encourage you to seek out some resources and be in touch with Jason, myself, and Milena if you'd like some of those resources. You can assist in helping residents make new decisions regarding their situation, and also decisions about what type of care and support services they'd like to access, what they're ready to engage in at this time. Also supporting the resident in expressing their opinions and preferences, letting them know that their perspective, their opinion, their preferences are valued, are important, that they do have worth and dignity as a human being. And finally, to give advice when requested. There's we're understanding more and more about the concept of unsolicited advice and how that can actually have a detrimental effect. It can cause, when advice or suggestions are given before someone sort of gives permission to receive them, it can actually cause a knee-jerk reaction where folks feel that their agency or their independence is being threatened or reduced, and so they're more likely to not accept or not follow the advice that is given if they haven't already expressed a willingness or readiness to receive that advice. But certainly, if an individual seems open to it, then it is very appropriate for staff in recovery residences to provide advice about how they've dealt with trauma, coping skills that have worked for them, and maybe professional services that have helped relieve some of the symptoms. If folks have additional ideas here about what your roles, what you can bring to the table in terms of trauma-informed care in your specific setting, please add those in the chat box. We'd love to gather those. Give me a second to find my place. All right. So we've talked about the danger of re-traumatization in care settings, and we also understand that trauma-informed care is not the clinical treatment or counseling for trauma. It's really about creating a supportive and trauma-informed environment that that can help a person regain a sense of safety and confidence and control over their own life, and after which, spending time in that environment, they may choose or become ready to enter into professional treatment for trauma. But trauma-informed care itself is not that clinical treatment for trauma, which should only be undertaken by those with specific training and certification. Still, I'm sure that it's very common among those of you participating in the presentation today to have experiences where folks in your recovery residences begin sharing details, even unprovoked or out of nowhere. They might begin to share some details of their history, including traumatic experiences that they've endured. So one important thing in a trauma-informed context to think about is, how do we respond to that? How do we make sure that someone is able to vent if necessary, relieve some pressure, express themselves, and share with others what they want to share, but also avoid re-traumatizing themselves or developing symptoms that may make it more difficult to avoid relapse. So here's some tips on what you can do when someone begins sharing some traumatic experiences that they've experienced, how you can help them avoid opening the box too much before they're ready, and also how you can help them sort of repack the box to make sure that they regain a sense of safety and control after they've shared what they'd like to. You can listen compassionately without interrupting or sharing your own details. It can really be counterproductive when one person is sharing details from their trauma history to offer your own, or to counter with, well, I understand where you're coming from because this happened to me, or I know what you're talking about because this, the same thing happened to my friend. It's best to just listen actively to the person's own narrative without interrupting or responding with your own comparisons. Also, encourage the individual to consider not unpacking, to stop sharing for the moment. If they start to seem to become agitated, if they start losing control of their emotional regulation, or if for instance they might start shaking or becoming angry, almost like they're reliving some of the traumatic experience. In that case, it would be very very beneficial for them and for the stability in your house if you're able to sort of gently encourage them to not go any further. You can attempt to distract them, change the activity, ask them to, if they'd like to take a walk and go do a different, change the surroundings and change the topic. And you can even explain to them what you know about what could possibly happen if they completely unpack their trauma history, either before they're ready or before they have adequate support and coping skills to deal with it. Also, you can, again, back to your ability to model and share practice coping skills. Once after someone shares something troubling or distressing to themselves, it's a great opportunity to say, you know what, that brings up a lot of emotions, a lot of energy for me. And sometimes when I feel this way, one thing I do to help me sort of calm myself or soothe myself, regain my composure, is this. And you can either explain it to them or offer to practice it together and teach that coping skill to them. Ask them if they have skills, if they have certain techniques that they've found useful for themselves. They activate their prior knowledge and their experience with coping skills. You might learn something new, and it also will increase the individual's sense of having something to contribute. And finally, the last suggestion is that when someone is sharing something traumatic that they've experienced, that's also a great opportunity to sort of plant a seed or to gently guide them towards considering professional trauma counseling or treatment. You can offer to connect them with the resource officer or whoever's in charge of managing and sharing resources in the home, or explaining how one goes about entering services and completing assessments for specialized treatment of trauma or any other issues that one might be ready to address in treatment. All right, so moving on to some approaches that are aligned with and support trauma-informed approaches. These here, person-centered care, whole person care, strength-based approaches, shared decision-making, motivational interviewing, and certainly mindfulness, are all approaches and practices that strive to treat every individual with humanity and respect, recognize individual strengths and utilize them in service of individuals' recovery, and also help folks rebuild their personal senses of control, safety, and dignity. We're not going to have time to go into too much detail about any of these approaches here, but we're going to do a quick overview of some of them, just so you're more familiar with the concepts. A lot of these sort of can seem like buzzwords that we hear a lot, but we might not fully understand what is meant by them. So hopefully in the next few slides, we're going to increase your familiarity with them and maybe even provide some takeaways, some ideas of what you might want to look into or seek additional training in the future. So first, with person-centered care. Person-centered care is all about remembering that treatment and recovery support should be focused on respecting the needs and preferences of the individual. Despite our personal experiences, our personal values, or our what may be firmly rooted beliefs of our own about what is required for sobriety and recovery, in person-centered care, it really means that the client is the expert about their needs. They know best about what may be helpful for them at any given time. Also, they deserve to always have their culture and preferences validated and respected. And we as either recovery residents, operators, service staff, peers, or treatment providers, we always should seek to follow their lead and make sure that they have their opportunity to express their preferences, utilize their knowledge about themselves, and make decisions about what occurs for them. In person-centered care, the strengths, personal knowledge, and experiences that the individual brings to treatment or the recovery setting are valued and sought to be utilized just as much as those of the professional or the staff member, if not even a bit more. And that's what's attempted to be visualized in this Venn diagram I put together. It shows here on the resident side what the resident brings to the recovery environment, to the recovery house, their own cultural, historical, and gender issues, their personal trauma background, their life experiences, the way that social determinants of health have shaped their individual health and outcomes, their personal preferences, what they've learned about what works for them and what doesn't work for them throughout their treatment history. Also, their own co-occurring disorders, their both physical and mental health conditions, in addition to their substance use conditions, and whatever strengths and resiliency factors that they bring. That together, what the resident brings is partnered with what the professional staff brings, which is the staff's education and knowledge, their expertise in recovery and recovery environments and treatment, their professional experience, the staff members' familiarity with different treatment modalities, settings, systems of care and recovery environments, and familiarity with healthcare systems and available resources in the community. Where those overlap, they're of equal importance, and where they overlap and work together collaboratively, that's where person-centered care exists. And that's hopefully what's visualized by that Venn diagram. An additional definition of person-centered care is that the experience, to the extent that the informed individual in recovery desires, of transparency, individualization, recognition, respect, dignity, and choice in all matters, without exception, related to one's person, circumstances, and interventions in healthcare. That is what person-centered care means, and that's what we might not always be able to provide in our recovery residence, because it's not a treatment center, but this is where we can come into supporting residents in advocating for themselves, in knowing what the ideal standard is and what they should be looking for when they do seek professional services or treatment. And unfortunately, this, in my experience, this is very uncommonly what folks actually do experience in inpatient and outpatient treatment for substance use. The next approach that we're going to briefly introduce or discuss is whole person care. And whole person care really recognizes that all these different domains here, the bullet points, physical health needs, behavioral health needs, trauma exposure and response, functional status as far as abilities with physical health, mental health, and activities of daily living, the environment in which someone lives and has the opportunity to recover and get support, and also opportunities to fulfill their full potential. All of those different domains of health need to be addressed and strengthened in order for an individual to actually achieve full holistic health, which can also be thought of as achieving or maintaining an optimal level of functioning for that individual. I assume that we all know and agree that an individual is always much more than simply their addiction or their diagnosis. And if we want to really support them to the best of our ability while they're with us in on their recovery journey, we would do well to consider all realms of their lives, all of these different sections and their different functioning capacities, and seek to offer resources or support when necessary in order to intervene sufficiently or address whatever deficits or needs they may have in whatever area. An example that I like to give in talking about whole person care is, imagine an individual who is a childhood sexual abuse survivor, who is now struggling with chronic symptoms of PTSD. They're also new to this area, and they have few local supports or contacts in order to access for support. This type of an individual is certainly going to need much more than withdrawal management or detox for a couple days, and then 28 days of inpatient treatment or 6 months of IOP in order to have all of their whole person needs addressed. They're very likely going to also need mental health support, physical health support and care, as well as information about resources and connections in the community. So that example for me sort of really brings it into clarity, the importance of thinking about whole person care and all of those domains that exist for a person's health, beyond simply their substance use needs and recovery needs. This slide is just a nice visualization of the different components of whole person care. We can see that there's personal care and physical well-being, work and occupation, sort of that's the purpose for our life, being knowing that we are competent in at least some areas and able to contribute to others in society, our needs for caring and supportive relationships, resources such as finance and money, ability to gather those resources for ourselves, social, cultural, and spiritual needs, education and training, different accommodations based on our different abilities, and also medical and other forms of treatment, including psychological interventions. A challenge, we're not going to have time to discuss this morning, we're getting low on time, but a challenge that I'd like to all offer you to consider is which categories here do you feel are most often unaddressed by either substance use disorder treatment providers or in recovery residencies? Which areas do you think that you might be able to strengthen what you offer or how you support the individuals in your recovery residencies? Any sort of additional support that you can offer for any of these domains is going to serve the person well, not only for their holistic health, but also in their recovery from substance use. Okay, the next approach is called shared decision making. This is really about collaboration and mutuality, making sure that each individual has the opportunity to express their preferences and have their preferences, ideas, and experience and ideas about what would work best for them respected. So when clients are ready to make a change, and I believe that by the time they get to you in recovery residencies, they have already demonstrated that they are ready for a change. Shared decision making is a process where operators and residents can work together to make decisions about the daily lives of the individual in recovery, to select services, treatments, and outcome measures, and to develop crisis and relapse prevention plans as part of the recovery activities. Shared decision making is always a key component of trauma-informed and patient-centered practices, because it emphasizes the residents, the individual's preferences and values, and serves to offer opportunities to restore individual control and safety for the individual who most likely has lost some of that through experiences with trauma. And it also works great because it reduces resistance. It often serves to increase buy-in on the part of the residents if they feel like they've been able to have a say and that their preferences are respected in any decisions that are made about things that affect their personal life. This here is a nice visual, another nice visual of what shared decision making might look like. And it's somewhat similar to the diagram for person-centered care, but here it's displaying how the attributes of the operator on the left side and the resident on the right side can be balanced in order to facilitate genuine collaboration and mutuality with respect for what each party brings to the table in the decision-making process. And here is a handy acronym that was developed by the Agency for Healthcare Research and Quality that really lays out in just 5 simple steps the essential components of shared decision-making. And it's an easy to remember acronym. Step 1 is to seek the person's participation, to invite them to participate in the decision-making process, to let them know this might be different from other treatment or recovery experiences that they've engaged in, where most of the decisions might be made for them, where they're directed or told what's going to happen and what they're going to participate in. So it's inviting the person to be an active and 50% member of the process. Step 2 is to help the person explore and compare different treatment and recovery environment options, activities, and services. This is where the recovery resident staff can utilize their expertise, their experience, and familiarity with what options and resources are available. Step 3 is to encourage and support the resident to assess their own values and preferences, to elicit what are their ideas about what might work best, what sounds good, what might they be most interested in trying at this point. Step 4 is to reach a decision with the person. Balance all of those values and preferences, opinions and ideas, and help them make a decision that they can take some ownership with, that they can feel confident that they had a role in making. And finally, step 5, this is down the road, but evaluate the decision collaboratively. If things didn't go so great, keep an open mind, elicit the individual's ideas of what might have been missing or what could be done differently next time. And invite them to re-engage, go back to step 1 with this shared decision-making framework. All right, and finally, the last approach that we're gonna briefly touch on today is motivational interviewing, or MI, which is something that I imagine many of you are somewhat familiar with or have at least had some training or experience with. Motivational interviewing is, for many years now, I would say almost decades, it's been, we've known that motivational interviewing works really well to engage people at different stages of readiness for change in treatment, and can sort of uncover and elicit internal motivation for change, and support people in increasing their motivation for change. So motivational interviewing is a strength-based approach as opposed to a weakness-based approach, and it seeks to elicit and build on the individual's intrinsic abilities and motivations for change. It started as an adaptation and extension of Carl Rogers' humanistic, person-centered counseling style. Carl Rogers is the therapist who developed the concept of unconditional positive regard. Every individual, whether they're in treatment or not, deserves to have some outlet, some space where they are not subject to any judgment, any criticism, where no matter what they share or what they do, they are still treated with positive regard. And that is also, that's carried over into motivational interviewing. The core skills of motivational interviewing are the utilization of open-ended questions, which seek to encourage a person to sort of open up and share more than they might intend to, and also demonstrate that we're interested and we care about their ideas and their thoughts. Also affirmations, which encourage to bolster self-esteem and self-confidence. Reflections, which serve to let the other individual know that we're following along, that we're understanding them, and that we're on the same page, and we're encouraging them to continue on this thread. And finally, summaries that can really serve to help people put it all together and then move on to the next step in their readiness for change or their decision-making process. All of these are the core skills of MI, the most commonly utilized skills, are really the basis for change-focused conversations, which are termed interviews in most motivational interviewing with individuals at different stages of readiness for treatment and recovery. And even though MI, it's motivational interviewing, it's a conversational technique. It's just as much a way of being with someone and communicating with them as it is a therapeutic approach to counseling. I really just feel that motivational interviewing, some of the skills and techniques are just key components to really, really great, effective, inoffensive communication, supportive communication that demonstrates to the other person that we're interested and that we care. Here's a few more points about motivational interviewing. We seek to, with different MI skills and techniques, we seek to increase the confidence and skills for positive change in the individual by eliciting their own inherent motivation for change, affirming them and their abilities, emphasizing that they are free to make the decisions that they have in front of them, and also encouraging optimism that they can be successful with the changes they're interested in. And I see we just have a couple more minutes, so I'm going to skip through that so we can watch this very short 2-minute video. This is a 2-minute explanation or introduction to motivational interviewing by Bill Miller, who's one of the 2 clinical psychologists who first developed motivational interviewing with Stephen Rolnick in the 1970s as part of their observations and research with folks in treatment for alcohol use disorder. And I'm going to make sure that you can hear it this time. But raise your hand, or Jason, please let me know if you can't hear this. Here we go.
Fundamentally, motivational interviewing involves a change in role, a change in how you think about what you're doing. You're not the expert there to fix the person. You don't have to make the person change. The truth is, in fact, that you can't make a person change. You don't have to be the one to come up with all the good ideas. A person with really good ideas is sitting across from you and may have better ideas than you do. It's not like a competitive sport. It's not like wrestling where you try to defeat and pin and outsmart and outwit the person. It's more like dancing together, moving together, adjusting your movements to the other person. Overall, motivational interviewing is not a directive approach. Neither is it just a following approach. Following is listening to the person and kind of going wherever they go. Motivational interviewing is in the middle, between those two, and we describe it as guiding. If you go to another country and you hire a guide, you don't expect the guide just to follow you around. That's not what you're looking for. Neither do you expect the guide to order you when you will arrive, when you will leave, what you want to see, what you will enjoy, what you're going to do. That's not a good guide either. Good guiding involves good listening, as well as using your own expertise. A good guide will find out where you want to go, what you're interested in, what you're hoping for on this journey, and then help you get there using his or her own expertise, enjoyably, safely, efficiently, perhaps. That's the guide's job. Not solely directing, not solely following. There's some of each in it, but it's a blend of those things. This may or may not be the way you've been thinking about your own work, but we invite you to try it out.
All right. So Bill Miller invites you to try out motivational interviewing, and I strongly encourage you to look out for any training opportunities that you have in motivational interviewing. There's also a lot of videos with demonstrations. There's a lot of articles that you can find just by searching on Google. And I fully have full confidence that you will experience for yourself the power and benefit of motivational interviewing techniques if you have a chance to learn them and begin just practice implementing them. Usually that's all it takes for someone to be convinced and then never stop wanting to learn more about motivational interviewing. That's certainly been my experience. Okay. We're just about at the end. Yes. So for bringing it all together, this is our conclusion. The conclusion opportunity for you all to participate in the chat box. It'll be great if you'd like to share with us which of these approaches that we've covered today that you have already had experience with and that you found beneficial in your work, or those that you think sound really interesting and might be worth learning more about and trying to apply in your setting. Also, it would be great if you are willing to share what are your takeaways from today's presentation.
And
Well,
Garrett,
yes.
we only have a minute left. So I am mindful of that. And I just want to make sure Jason doesn't have any closing remarks. Please do chat in to the chat box if you have any feedback for us. Otherwise, I'll let Jason give any closing remarks.
Absolutely. Garrett, I do want to thank you for your time today. A lot of very wonderful, great information you were able to share with everyone today. And Milena, I want to thank you as well for your time here today. If any of you have any final thoughts or questions, go ahead and post those in the chat box or in the question and answer section, and we will do our best to get those answered. Again, there were a couple questions about these slides or this presentation as a whole being available. This whole presentation that Garrett and Milena presented on today will be available on the WAQRR website this evening. Again, I want to thank all of you for your time here today.
Thank you all very much. It's been a pleasure. And feel free to contact Jason, who will then get in touch with us if you have any questions, comments, or requests for more resources or information about any of the topics discussed today.